Hello everyone, today we are going to study about the preterm labor. So let's go with the topic. So preterm labor is defined as one where the labor starts before the 37th completed week or less than 259 days. Then it is defined as the preterm labor, and there is early preterm labor and the late preterm labor. Labor starts before the 34 weeks, then it is termed as early preterm labor, and if it occurs after the 34 and to the 37 week, then it is late preterm labor. So what are the causes of preterm labor? So like spontaneous unexplained preterm labor with intact membrane, preterm premature rupture of the membrane, iatrogenic like induced preterm labor, and the multiple pregnancy. These are the main causes of preterm birth. So what are the associated findings which we see in the preterm labor? Like maternal fetal stress there can be, and polyhydramnios, and the intrauterine infection, bleeding, cervical insufficiency, and the uterine abnormality are also seen. So what are the contributing factor or which increases the risks of the preterm labor are like, which we should not forget is that if there is the history of prior preterm birth, then it is the most important contributing factor. And the extremes of maternal weight and the age, and the bleeding in early pregnancy, short inter-pregnancy interval, and the chronic stress, smoking, chronic gum infection, and the bacterial vaginosis. So bacterial vaginosis and the history of prior preterm birth are the main important contributing factor, and other are also plays role in this. So what for the diagnosis of preterm labor? So regular uterine contraction with or without pain, so at least 1 in every 10 minutes, and the dilatation greater than 2 centimeter, and effacement 80% of the cervix, and the length of the cervix is less or equal to 2.5 centimeter, and funneling of the internal seen, and the pelvic pressure, backache, and or vaginal discharge or bleeding. So these are the features to diagnose of the preterm labor. And preterm labor is unlikely when the cervical length is greater than 33 millimeter, irrespective of the uterine contraction. So we should have to know about this. So what is the etiopathogenesis of the preterm labor? Firstly, like activation of the fetal age PA axis, which increases the CRH and the cortisol, and also other factor like choreo residual bacterial colonization, which increases the TNF, interleukin 1, 6, 8, and the pathologic uterine enlargement like polyhydramnios, multiple pregnancy, that increases the mechanical strength, stretch, and interleukin 8, gap junction, and the prostaglandin synthetase. So that there will be chorion, amnion, and the decidua, then there will be the increase of prostaglandin E2, F2 alpha, thromboxane A2, leukotrienes, prostaglandin dehydrogenase, proteases, collagenase, and the leukocyte elastase, so that it contribute to the myometrial contraction, increase cervical ripening, and the cervical insufficiency will also be increased, so that it gives like contribute to the preterm labor and the delivery. So for the predictor of the preterm labor, as it is divided into three predictor: clinical, biophysical, and the biochemical predictor. So for the clinical predictor, like history of the prior preterm birth, which is important, which we have talked earlier, and also multiple pregnancy, presence of genital tract infection, symptom of preterm labor, then it is the clinical predictors. And there is biophysical predictors like uterine contraction greater or equal to 4 hours, and the Bishop score is greater or equal to 4, and the cervical length is less or equal to 25 millimeter. So biochemical predictor is fetal fibronectin in cervicovaginal discharge, interleukin 6, interleukin 8, and the TNF alpha. So let's talk about the fetal fibronectin in something detail. Okay, for the fetal fibronectin, like it is the glycoprotein that binds the fetal membrane to the decidua. Like if this is the fetal membrane, that this is decidua, like this is the uh, fibronectin. So it acts as a glue between the fetal membrane and the decidua. So normally it is found presence in the cervicovaginal discharge before 22 weeks, and after, like normally it is seen before 22 weeks and after the 37 weeks. Okay, but if we see it in the in between this period, like from the 24 to 37 week, then we can predict the preterm labor. So prediction is not much like if fibronectin is positive, then the predictive value is low, as it means that if like fibronectin is positive in the cervicovaginal discharge, then there is it is the for the diagnosis of the preterm labor, then the predictive value is low, like only less percent of the people who are positive with the fibronectin may go to the preterm labor. But if negative, then prediction value, if there is no fibronectin, then there is no like very high chance that there will be no not occurrence of the preterm labor. So where it is important is that if there is more patient, like many patients are coming in the OPD or the hospital, and then you have to choose who to treat, like who to give the priority and who is really suffering, so that to exclude then if the fibronectin is negative, then there is high chance that there is no any occurrence of the preterm labor, so we can send them home. But if it is positive, then only like predictive value is low. So for the like management of the patient in the hospital, it is like the negative value will be very helpful. So management of preterm labor is, it includes to prevent the preterm onset of labor, like firstly to prevent the onset of labor, and if there it is occurring, to arrest the preterm labor if not contraindicated. Like many conditions there are contraindication or indication of the preterm labor, so if there is no any contraindication, then we can arrest. And the appropriate management of the labor, if it is occurring, then we have to appropriate management of labor and the effective neonatal care after the delivery. So for the prevention of the preterm labor, firstly we can do is primary care. Aim to reduce the incidence of the preterm labor by reducing the high risk factor, like which high risk factor we have talked earlier, but some high risk factor we can minimize, like infection, that we have to reduce the high risk factors. And the secondary care includes the screening test for early detection and prophylactic treatment, so that we can use the other method to prevent the preterm labor. And the tertiary care is aimed to reduce the perinatal morbidity and the mortality after the diagnosis, like use of the corticosteroid, which helps to mature the lungs in the preterm labor. So what are the measures to arrest the preterm labor? We can, like patient can have bed rest, adequate hydration, prophylactic cervical circlage can also be used to arrest the preterm labor. It is also used many cases in the OPD cases to like prevent the preterm labor. If there is history of the like cervical insufficiency or less cervical, then we can have the prophylactic cervical circlage. And the tocolytic agent like nifedipine, titodrin, terbutaline, indomethacin, and atosiban can be used. Like there can be asked of the question like why like tocolytic are used, then you have to say that to buy the time for steroids, and the second is to prepare the patient to transfer the patient to the higher center, because like if it cannot occur there, like if preterm labor, then we have to transfer the so if why the tocolytic agent are given in the preterm labor, then you have to say these 2 points which is asked by the teacher when you do the presentation. So what are the like glucocorticoid therapy? Mainly glucocorticoid therapy is due to accelerate the fetal lung maturity. So when to give is the pregnancy less than 34 week, then there is chance of like there is fetal lung maturity. So we have to give to the mother, and the drug of choice is dexamethasone and betamethasone. So for the remembering, like for the betamethasone, there will be 12 like para, okay, 12 mg for 24 hour for 2 days, so that you have to make the 24 mg dose for the patient. Like if you give the dexamethasone, then 6 mg, then for making the 25 mg we have to give for the 12 hourly for 2 days, so that 6 into 4 25 mg will be there. For remembering, betamethasone, which is in Nepali 12, so BB 12 betamethasone 12 mg, and then we have to make the 25 mg, so that for the 2 days 24 hourly, which is same. So 25 mg, and for the 6 mg we have to do for the 4 times 12 hourly. So for the principle of the management, to prevent the birth asphyxia and the development of respiratory distress syndrome, and to prevent the birth trauma, like duration of the labor will be usually short. So for the first reason, the patient is put to the bed to prevent early rupture of the membrane, to ensure adequate fetal oxygenation, and the epidural anesthesia is of choice, and the labor should be carefully monitored, preferably with continuous EFM. And the cesarean delivery is done for obstetric reason only, like hypertension, abruption, and the malpresentation. NICU is a sine qua non for good outcome. So for the second stage, the birth should be gentle and slow to avoid rapid compression and the decompression of the head. Episiotomy may be done to minimize the head compression if there is perineal resistance, which I have already talked that in the video of episiotomy, which you can watch also. Tendency to delay in curtailed by low forceps, as such routine forceps is not indicated. Like for the forceps, we have also make the video, you can watch. Okay. And for the cord is to be clamped immediately at birth to prevent hypervolemia and hyperbilirubinemia. Mainly there is saying that we have to delay the cord clamping, but in this case we have to immediately clamp the cord, and to ship the baby to neonatal intensive care unit under the care of the neonatologist. So another condition in which preterm labor allowed it to progress, like if there is the occurrence of active labor, then there is no effective to stop restrict the labor, so we have to allow the pregnancy more than 34 weeks. Then there is lungs mature, so there is not like benefit of stopping the labor. And the abruption, if there is abruption, then we have to allow to progress. Fetal compromise, then we have to allow chorioamniotis and the dead fetus, or pre-eclampsia and the eclampsia, then we have to allow the progress of the labor. These are the reference. Thank you.